Welcome, everyone.
This meeting is being recorded.
This meeting is being recorded as we start. I want to make this just very casual, a conversation. My name is Lily Jimenez. I'm a neurologic physical therapist. I welcome any questions through the chat. I'll be paying attention to the chat just in case if you have questions, or feel free to, unmute yourselves and ask questions. We're here to talk about neuro PT, my favorite thing in the whole world. So it's super exciting to talk about this because I've always thought, I wish I had someone to go to a coffee shop and just talk about neuro all day, which this is kind of like the same thing, but we're not at a coffee shop. We'll just have water or whatever drink you have there. So just a little bit about myself. I live in El Paso, Texas. I practice in El Paso, Texas as well. I was born here in El Paso and I actually grew up in Mexico, so I'm bilingual. I graduated from UT El Paso in 2017 with my doctor of physical therapy. And then I worked for a year. So that was in 2017. I started practicing in 2018. I worked at the county hospital. And I was lucky enough that they just opened the neuro ICU when I graduated. So I kind of was lucky enough to be the PT in the neuro ICU, a new grad. So it was a little bit scary, but it was fun. And then I knew I wanted to do residency because I wanted to be a neuro PT. And I wanted to be trained by a mentor. Who was an NCS. So I applied to residency. I went to Kaiser Permanente, Northern California. And I was there for a year. So that was 2019 to 2020. So yes, I was half of the time there with the COVID thing and it was different. But then I came back to El Paso. I studied for my NCS. Hardest exam ever, but I passed. And then now I'm practicing at an inpatient rehab. I see all types of populations, but mainly we do see, neuro and some ortho. Sometimes we see some cardio. I'm per diem, so I don't get to see a full caseload. But recently I started teaching at UT El Paso, so I'm in charge of the neuro rehab curriculum. And that's fun because I fill the neuro gap with some teaching, which I love. Let's see, more about who I am. I am about to become a mom. So I have mommy brain. So I am so grateful for reminders because I would forget everything. So I'm about to become a mom next month. I'm expecting a girl. And I love to cook, but I don't have the energy to cook anymore. And let's see what else. A fun fact about me: when I was in my residency, since I was by myself there, right? I didn't have anybody living with me, so I became a plant expert, like a house plant expert. So I had like 30 house plants inside my apartment, and I just would go to nurseries and research plants and when I moved back to El Paso, I had my full SUV, the back of the SUV full of plants. So that was something that I was like, what was I thinking? Anyway, so that's me. Thank you. Congrats. I assume because of the baby. But I welcome any questions. Or if you, Terrell, you want to ask questions for the audience, please feel free to shoot them at me. We'll make this a casual conversation. And now I'm gonna drink water because now I'm short of breath.
No, absolutely. So I guess we could start with what was it if it was like a baby aha moment or the big aha moment while you were in PT school that made you think that you would want to go down the neuro path?
Yeah, so that's a very great question because actually, no. This, I consider just, what I call being a neuro lover, a true calling for me, because I actually started with that interest since I was in undergrad. So we had to choose several science classes. And most people would take genetics at UTEP as their optional class. So I didn't take that. I took neuroscience, and then I started volunteering at neuroscience lab. I was cutting rat brains. I was just like full into the neuro field. And then when I got into PT school, you like everything when you're in PT school. You like ortho, you like peds, you like cardio, you like neuro. So I was very open-minded about it. But I knew that I really like neuro. Neuro was one of those classes that I really wanted to do good at in case if I wanted to do residency. So when I went to my rotations, my first rotation was in Austin at the county hospital, which was UMC Brackenridge back then. I just loved treating people who had strokes in the acute setting. And I remember the day that I was at a coffee shop with a friend, and I told him, I think my calling is to be a stroke PT. So then, I had my ortho rotation. I was not good at it at all. And then I had another neuro rotation, which was at Timber Ridge Ranch, which is in Arkansas, brain injury rehabilitation. I loved it. And then my final one was an inpatient rehab, and I loved it. So, you go into PT school loving everything, but it's not until rotations that your true liking or what your passion is reinforced through the experience. And then you start discovering what are your strengths and your weaknesses. For me, ortho was my weakness. So, and then neuro just came very naturally. So that's how everything just quote unquote started for me. And I'm seeing some comments here in the chat. Hi, Dr. J, what are your thoughts on starting a residency immediately after PT school versus waiting a few years? So that's a great question, because, when I started to apply to residencies, there were a lot of applicants who just applied immediately. And some residencies do prefer new grads than actual therapists. Just because they can teach you from zero, right? So you don't need to quote unquote unlearn what you've learned. So I've heard that, but there is a benefit of once, if you practice, let's say for a year, like I did, I already have experience with documentation. I'm already proficient in documentation. I'm already used to a caseload. I'm already, confident in my skills. So there are benefits, but I think residencies, they don't care if you're a new grad or if you have 2-3 years of experience or more. So it just depends on your application. If it's strong, if you have leadership, if you have service to the community, etc. So that's a good question. Sorry, I'm jumping from topic to topic. I hope you all don't mind. So I see another comment here, Catherine Carley. I'm 100% going to pursue neuro PT. Yes, it's the best decision you can take. I love it. Right now, I'm weighing the pros and cons of residency after school. So kind of the same comment as Charwin. I'd love to hear more about your decision to do residency before taking NCS. So residencies, you really need to think about residency as a way for you to be vulnerable and show your weaknesses in front of an expert therapist and be able to grow from that. Because residency, what they teach you is, to discover your weaknesses as a neurotherapist, and then, teach you to be an expert. So don't think about it as a way to facilitate your NCS pass rate. It's more of a skill thinking the process of improvement, something like that. So also residency, you need to think about it as training where you really are looking for someone to guide you how to become the best version of yourself as a therapist, as a neurotherapist. Because people who are training you in residency are people who have lots of experience in the field. So think about it that way. The NCS, of course, yeah, seeing, patients and diagnosis help me study for the NCS in the way that I will remember. Let's say if I was studying about, I don't know, Parkinson's disease, I will remember my patients from residency with Parkinson's, but didn't really exactly help me like improve my passing rate. It was more I will bring the experience with me as I was studying, and then it would help me remember some concepts. But think about residency as a way for you to improve yourself as a therapist versus improving your NCS pass or fail rate. So that's what I have to say about it. So Carter Gansky says, I'm a second-year student looking into clinical rotations. Do you have any recommendations in Texas for specific neuro PTs or facilities? So in Texas, I know Dallas has UT Southwestern. They have a residency and a abnormal gait clinic. So I don't know if students can go in there. There's always Tier Memorial Hermann in Houston, which would be great. It's a great neuro inpatient rehab facility. I would have loved to know, or before when I was a student, I would have loved going to Tier, but I didn't know about it. But Tier would be great. Let's see what else. Honestly, in any inpatient rehabilitation facility, you will find neuro patients, in all of them. If I don't know any outpatient facilities in Texas, to be honest, but I would say talk to your director of clinical education to see which are some of the inpatient rehabs that you can go, or if you have one in mind, you can always present that option to your DCE and they can help you with that connection to have a neuro rotation. But I'm not a lot of, I don't know a lot of Texas. I know some out of town, but in Texas, I know the biggest one is Tier in Houston. So let's say Ethan Triplet says, what are the job opportunities like for neuro PTs? Is it hard to find positions? I don't think so, because well, if you're an NCS, of course, if you apply to any neuro or a big neuro rehab hospital, they will see your credentials and you are obviously qualified to perform any type of neuro intervention if you have an NCS. So I don't think you would have problem finding a job as a neuro PT, or even if you don't do NCS and if you have experience in neurotherapy, I don't think you should have any problem. There's many jobs for PTs out there. I don't think we should have problems finding a job. We are highly needed everywhere. And the good thing is neuro PTs can find neuro patients in any setting, right? In acute care, you will find in the ICU, people who had strokes, people who have encephalopathies. If you work at a trauma center, you will find your people who had spinal cord injuries or brain injuries, especially your trauma 1 centers. So you will find neuro patients everywhere. And if you don't find them, they will come to you. That's what someone told me a long time ago. Is it possible to specialize in ortho and neuro? Actually, there was a time in my life that I wanted to do OCS and NCS, but after going through the NCS process, I am not that brave to take another specialty exam again. But absolutely, I think ortho is so important when you work with someone with neuro diagnosis, because let's say for stroke survivors, you have your shoulder dislocations, your shoulder pain, your shoulder imbalance. When you have hemiplegia, you have your musculoskeletal issues. So absolutely. So that's a wonderful combo. If you want to specialize in both, I would say if you love both, do both. I would do it, but I'm not brave to study again as hard. Also, are there a good bit of neuro residencies? There are, so let me see. There are a lot. If you go to neuropt.org, you can go to, let me see, professional resources, and there's the option for neurologic residency, and they list all the residencies in the US. So there's quite a few. There's a lot of residencies. The only thing is residency, they're quite competitive. So they accept, maybe 1, 2, some residencies, 3 PTs per year. But I think there's quite a lot of residencies around the US available. Of course, there's more for like ortho, but ortho and neuro, I think, are the biggest residencies in terms of number or quantity. Because I know other specialties like cardio or acute specialty or even women's health, they have fewer residencies, but ortho and neuro and peds are pretty big. So you should find, but go to neuropt.org and go to professional resources and neurologic residency, and they will list all the residencies in the US. Of course, you want to look for first in Texas, and then, you can explore other options around, the US. There are 63. Yes, you see, there's a lot of residencies. Let's see, where was I? Everyone doing okay so far? Let's see. Terrell Wallace says, what did a day in the life look like during your neuro residency? Did your residency include NCS exam prep? So I loved my period as a resident. I think that was the best investment in my career, even though I had to move. And number 2, of course, you get a little bit of a pay cut, but my time was the best. So I was in Northern California, so close to San Francisco. And so my day would be, so in acute care, because I had an acute care rotation and then I had a outpatient rotation. My residency did not have inpatient rehab, and that is something that you can explore when you are looking for residency. So you can, if you like acute care and you like inpatient rehab, you can, of course, ask or email the residency, or even just research, what settings are you going to be in. So mine didn't have inpatient rehab. I just had outpatient and acute care. But I didn't mind, I didn't have inpatient rehab because I love acute care and I'd never had any experience in outpatient, so that was new for me. So my day in acute care, I lived very close, so I would, wake up and then I would get to my, it was the hospital. I would have a caseload of around 9 patients. So let's talk about the mentor day, since that's what, the residencies is. So mentor day was once a week. And for me, it was on Thursdays with my mentor in the morning. So my mentor would get there with me in the morning. We would chart review together. We would check imaging to see, where the stroke was, or what tumor or tumor was, or where, or other brain abnormalities. We would discuss which one I wanted to get mentored in. So I would pick, some of them that were challenging, because we only had the morning for mentoring. So let's say I would pick like 3 or 4 patients to be mentored, So then we would go in, I would treat, and she would be more like a fly on the wall, just observing what I was doing. like, if you're in a practical exam. But it was more comfortable because, we already have the confidence and the skill, and we as PTs, we are like, okay, well, I think I know how to do this. So my mentor, she was awesome. So after the patient or patients, we would debrief. And, she would tell me, how did it go? Anything you want to discuss about this patient or anything different? She would ask questions, let's say, I remember one time, she asked me questions of like, how would you improve this patient's proprioception? And then, we would brainstorm. Sometimes we would go to this little room that it had like a therapy table, and we would talk and discuss interventions and just like talk through it. And then that same day, when mentoring was done, I would finish up my caseload by myself. And then in the afternoon, I would receive what it's a reflection form. So she would provide feedback on each patient we saw. And then she would ask questions that would make me reflect about, the patients we saw. So for example, she would ask something like, how did you feel when the family member asked you this? What could you have said? Any article that you can find about this diagnosis, so things like that. So it would make me think about what happened. And that's how residencies develop your what's called a metacognition, which is thinking about what you are thinking at the moment. So and that was the mentoring days. So that's usually how my day was. And then, at the end of the day, it was just normal life for me. Sometimes I would have work to do from residency. Towards the end, we had capstone. Or, I would research articles. I would work on other stuff like prep for teaching, because we also had teaching opportunities. So it just depended on what work we had for that specific period of time. In outpatient, my days were longer because it was an 8 to 5. And the difference there was because it was COVID times, I did transition into telehealth. So I had patients through video cam, neuro patients, and it was just a different type of neurotherapy, because it was a lot of education versus actual hands-on. So I learned a lot about communication and just being present when my patients were there. Through the video, I learned a lot about empathy, because your patient, you were not able to be there with them. It was through a video camera. So it was a different type of learning experience that I did not expect, but it did teach me a lot about communicating with patients. So my days were different because I was, it was a little odd because it was, COVID. So I would be in a room, no contact with anyone all day, patients through camera. And then towards the end, some patients, when they would feel more comfortable coming in, we would see them in person, but still it was when pandemic just started. So it was a little different. So I know that part of my residency would have been different if COVID was not, or it didn't happen. So that's usually how a day of a resident and mentor days were. So I forgot to say, I'm sorry. During my mentoring days through telehealth, my mentor would be there also in the video call with me. And again, she would just be like a fly on the wall and on mute. I would talk to the patient, provide the therapy through the camera, or phone if it was a phone call. And then towards the end of that morning, we would connect again and discuss. And that was very great because she did taught me a lot about empathy and communication again. So that was mentoring days. I don't know how it works in other residencies, but I loved how my, again, the metacognition, the thinking about what you're thinking in the moment developed. And it's a skill. So it seems weird, but you develop the skill of metacognition. So that was it. Sorry, it was a long response. Let's see. 5 neuro residencies in Texas. Yes, I think there is Tier, UT Southwestern. There is in Houston, there's Harris Health. I don't know the other two. I would have to look it up. As a DPT.
The 5 are Baylor, Scott and White,
Baylor.
Harris, Tier, UT Southwestern, and so I guess so Baylor for Mary Haldwin and Baylor for Texas Women's.
Oh, Texas Women's. That's right. That's right.
So there's one in Dallas and there's one in Waco.
There's another one. I almost forgot. I applied to this one. I can't believe I forgot. It's the one in Texas State in Round Rock. There's another neuro residency there. As a DPT who worked in the neuro setting before your neuro residency, what would you say the biggest differences are in how you treat? Oh my gosh. I would think about how would I treat it and I get embarrassed. I feel embarrassed. So, of course, the passion was there. I loved being a fresh PT, but looking back, of course I would get my patients better, but my neuro exam would look very different pre-residency than post-residency. Of course, I would apply principles that I learned in PT school for things like sitting balance. Since I was in the neuro ICU, they were lower level individuals. So we would work a lot on transfer, sitting balance, just being upright, sitting on those big chairs. But more than anything, I think the neuro exam is where it's just different, right? Before a residency, you would do a typical PT exam in acute care, but now when I have someone, post-stroke, which is the population I see the most, I pay attention to things like, eye movements, cranial nerves for oculomotor. I pay attention to anything different that I see in their bodies that might prompt me to think, or explore things like, looking at their pupils, things like seeing if there's any abnormal movements, more education, definitely, more talking about prognosis, because with experience, you learn about prognosis. It doesn't come right after, you graduate. It takes experience to know how a person with stroke will recover. But it's definitely, you don't have much experience. And once you have experience, it's your skills improve. It's repetition and repetition. So you get better. But, I think that will develop with time and with patience. Definitely. When you went through your residency, did you have to unlearn anything you learned while in PT school? Oh, that's a good question. I don't think I had to unlearn, because I think PT school does a really good job giving you the tools to start being successful with neuro patients. If anything, you just build on those skills. For example, if you learn about several type of interventions for your neuro patient, like I mentioned, sitting balance, right? In residency, you see those interventions more, you're able to see the purpose better than just being just an intervention, right? And as a neurotherapist, you think about, if I'm putting them in an upright position, I'm activating all these areas in the brain. Activating, let's say I'm going to throw some anatomical terms, you activate the reticular formation to help them be more awake. You activate their cerebellum for upright, you help activate. So you think more like that versus and as the new grad, you just think about sitting balance, right? So it helps you deepen that knowledge about what's the purpose of this intervention. and why am I doing it exactly? So that's something different that you learn about. How familiar, skilled do you have to be? With imaging? Honestly, I think it's a good skill to have. My residency didn't necessarily like push that I learn imaging per se. It was more like my choice to look at the imaging every day. And nobody taught me like, this is the imaging, this is how it should look, this is how stroke looks. Nobody taught me that. It was more of a discovery type of learning. So since I was in acute care, I had more access to imaging. So I would just see it for fun. And then as you see it, you start recognizing patterns. So you would start recognizing anatomy. You start recognizing like, hey, like this stroke looks more like up here versus down here. Or, you let's say you had a patient with a traumatic brain injury. So you would see the imaging and you would recognize, how does edema look like? How does a midline shift looks like? And then as you're looking at the imaging, you start pre seeing the patient, you start building up your like hypotheses on how the patient will present. So you don't really need to be familiar, but I think it's a fabulous thing to be familiar with, because you start being like, oh, that looks very suspicious, or like that looks like a big tumor, or that looks like a glioblastoma if a patient doesn't have a diagnosis. So you start getting familiar with all those pathologies. And same thing with ortho. If you start seeing your imaging, you start learning how to fracture look like, how to displace fracture looks like, how does all that. I don't have much experience in that, I have to say. Carter Gansky, what skills have you learned to better engage with patients with severe cognitive impairments, in the sense of basic communication, but also things like HEP? That's a great question, Carter. So people with severe cognitive impairments, the way you reach into their person is through exploring the person in that patient. So I'm going to give you an example. So this past week, I had a patient who was fairly young, so 50s, who unfortunately, if you remember, and if you've seen the movie A Beautiful Mind, which is about a gentleman who is very smart, and he went to, I think, MIT, or I don't know if it's Harvard. And then he was very smart, and out of a sudden he started to get a lot of like cognitive mental health difficulties. I think he had like schizophrenia. So I had this type of patient who went to MIT, who graduated from MIT, and now he has severe cognitive impairments. So he would repeat every 3 minutes, like, did I go to MIT? And I'm like, yes. Did I go to MIT? Every 5 minutes. And he would just not follow anything because of his cognitive impairments. So what I did to get him engaged is just, focus my session and throw him activities that would involve MIT. So that is what I call the salience principle. So exploring who they were, what they remember, and that will get them pretty engaged. Your commands or your activities should be more aimed toward being something functional, because if you have them do Therex, they're going to not do it. So things like something familiar, delivering candy, let's say in the unit, or picking up things for you. So having them do an activity that is more like a help me do this versus we're gonna do this 20 times or whatever. So, but communicating with them, it has to be straightforward. It has to be commands need to be short, and more like a, hey, let's go take a walk, versus I'm your physical therapist and now I'm going to have you walk around, so it just depends on how you use your words to connect with that person, and that brain. But for me, salience works very well. So if you have someone who, let's say, was a teacher, math teacher, maybe doing math activities, and PT would really connect with them. So that's my best advice. Reach out to what is meaningful to them, because people with cognitive impairments, could be brain injury, could be dementia, could be very challenging, and use your speech therapist to help you. But I think salience works very good. Our DPT curriculum from Terwas again. Our DPT, great questions here. I love it. DPT curriculum covers stroke, Parkinson's, and cranial nerves, pretty in depth. Are there any conditions that you see a vast amount in your caseload? Nope. Stroke is a major diagnosis. Parkinson's in outpatient is a major diagnosis. Cranial nerve, not so much. I mean, you do see some cranial nerve palsy sometimes, or involvement, but I think they cover the cranial nerves very in depth, because they are pretty important, and they involve a lot of, facial head stuff. And cranial nerves are involved in strokes and brain injuries and tumors and a lot of things. So that's why maybe I think, but stroke is a big one that I see, if anything. And in outpatient, you see a lot of Parkinson's and MS. But if you work in a trauma center or inpatient rehab, you might see your brain injuries a lot. Let's see. Oh my gosh, we're at the bottom of the questions. Anything that I haven't covered? Any question? Oh, I see one. What is a real life best way to catch a patient who's falling? Oh my God. So I've had this a couple months ago. Someone who was a high-level stroke survivor, she lost her balance, and she fell. But I think the best way in reality is to assist them to the floor. Because once a patient loses their balance, you start kind of freaking out, and you even are not aware what you're doing at that moment. So my best advice is help them slowly to the ground, versus, I mean, if you're able to catch them with gait belt and, if you're close to them, that's great. But sometimes just even allowing them to go to the floor slowly so they won't have any injury, that's the best thing you can do to prevent injuries. Because, after that, your adrenaline is going to be high. There's a code if you have if you're in an acute care or in inpatient rehab or any, facility where they call codes, there's going to be a code fall. Everyone's going to freak out. You're going to be a little embarrassed. It's just a lot of emotions. But I think that falling in the side of a PT, it's a good thing. Than falling by themselves in the room, because you know what to do, you know how to help them up. But the best way to catch a patient is, if you can't, just help them to the floor slowly. And so you're gonna have to go down with them slowly. Yeah, I know, gait belts. And also don't put the gait belt super high, try to keep it low, that way you have better control of these patients. Okay, so that's great. What would be your sales pitch to someone to try to encourage going into neuro? So here's my sales pitch. So neuro, I your emotions are valid, are valid, that neuro can be really scary when you're working with low level individuals, but also neuro can be super rewarding because one day you can see them do really bad and then the next week they are miraculously well. So every day they spent with you is a day where the brain is learning new things. And even if you get them to the edge of the bed, to be upright, their brain is already working. So you would see the biggest and the most dramatic changes in your patients when you work with a neuro patient, especially people with acute neuro events like a stroke or brain injury. So don't be afraid. They are as afraid as you are, and they are learning with you. And neuro patients, I think they are so resilient. And they really progress pretty dramatically. And some of the most dramatic patient improvements that I've seen have been like 1 week to the other. And I'm like, oh my God, this patient was not doing good this last week, and now they're walking. And I think the patients that surprise you the most are the ones that you think they're not gonna do well. They end up doing extremely well. So that is my little sales speech. Don't be afraid. They are as afraid as you, but they will do amazing. Yeah. Any other questions?
As terrified as I am, I will agree with the perseverance of the neuro patient, how fast they can progress. That's like the one thing that's keeping it like in my in my pocket. But through networking at CSM, and we have a student survey that we do with all of Texas, there's a lot of neuro interest. So I'm very thankful for that because it's not as high, for me. But but I'm glad a lot of people are interested in neuro for sure.
Yeah, I always say, doesn't matter if your interest is not neuro, just follow that passion and let that passion lead you where you need to be. If it's wound care, if it's pelvic therapy, if it's whatever, just let that passion lead you. It doesn't matter if it's not what other colleagues are telling you it's very cool. Like, for example, me, I can tell you how cool is neuro, but maybe someone else loves pelvic therapy and because their passion is pelvic therapy. So you just let your passion lead you as a therapist, and that will prevent you from being what I call, average therapist. You will be extraordinary if you follow your passion, because that's what's going to drive you forward a lot. Now I'm thinking, what am I going to do next? What am I going to do next? Because I love what I do, right? So let that passion lead you. That's all. And stay curious. That's what my mentor told me. Stay curious. Let's see. This has been so informative. Thank you. Thank you. I'm glad that this has been informative for everyone. Any other questions about the life of neuro PT?
Yes, last call before we let the mommy brain rest.
Oh, it's fine. It's okay. Thank you. Yeah, mainly stroke patients. Yes, those are awesome population to work with. They are so amazing. They progress so well, so well, even if they have massive strokes. Thank you, Ida, or Ida. I don't know how to pronounce your name. Ida.
It's Ida. Thanks.
Ida, hi. Well, everyone, if anyone has more questions, you can reach me in social media at the Brain PT. You can search me on Instagram. I don't have Facebook, but you can ask me questions. I post educational content on neuro rehab there. I'll put it in the chat here in case of you have that. Ooh. Let me see how to put everyone there.
Yep. So it's in the chat, and we'll share it to our social media as well, and we'll upload this video to. Yes, go follow. It's great. Kyle said you have to follow the Brain PT, and even with me being terrified of neuro, I'm in love with your Instagram. Like it's super duper informative.
As next week we're
And
gonna
I said,
talk about-
maybe I can't. But then
Yeah. Thank you. Yeah, next I try to post stuff, but now yeah, it's getting a little harder, but I do post stuff constantly. Soon we're gonna have a guest who will talk to us about his experience during residency interviews and his experience prepping for residency interviews, so that will come soon. But we always have guests talking to us about just neuro PT in general. But if anyone doesn't have any more questions.
Looks like it. Thank you so much for coming on. We really appreciate it, especially with the big changes that are coming in your life. We definitely are very grateful for your time and your knowledge and your sales pitch. That
Yeah. Hey, whenever
I don't know where I'm going next.
Whenever someone invites me to talk about neuro, I'm all in. So thank you for being here and for inviting me.
Awesome. So once I get this recording, it'll be uploaded to YouTube and all that good stuff. But pending no further questions, hope you have an amazing night. Get some rest. And thank you again.
Thank you so much, everyone. Thanks for coming. See you soon.
Thank you.
Thank you.